Okay, class, and wrapping up, we'll get into some interpretations. So the first kind of like condition that you'll see regarding blood pressure and heart rate issues is orthostatic intolerance. So orthostatic intolerance or hypotension is hypotension or reduction in blood pressure following a change in position. Typically, when moving from supine to standing. So normally, your blood pressure should normalize within about a minute with any position change. They should stay fairly stable. Again, we've got a lot of different feedback loops. Our baroreceptors are a big one that keep blood pressure normal throughout the body, irrespective of body position. Now, the symptoms patients report when they have this orthostatic intolerance, they'll get dizzy. They may get a change in mentation in terms of like they may have an altered mental status. They may get unstable, and they potentially may lose consciousness with the reduction in blood pressure, particularly again, we're looking at perfusion to the brain. A lot of different causes to this. There can be, it could be hypovolemic or dehydrated with low blood volume. You could have issues with your baroreflex. If you've been post-operative status, or you've been acutely on bed rest for a long period of time, or cardiogenic insufficiency, a lot of different reasons, certain medications as well. And there's also a subcondition, postural orthostatic tachycardia syndrome, which is related to an autonomic dysfunction where we have an exaggeration essentially in the heart rate response to the position changes. Now, our interpretation. So again, a normal response going from supine to standing is your heart rate should go up maybe 5 to 10 beats per minute. Again, the baroreflex kind of kicks in. Your systolic blood pressure may drop a little bit, but no more than about 10. And diastolic blood pressure should stay pretty much the same. An abnormal response would be a really exaggerated heart rate, going higher than about 30 beats per minute. Or systolic blood pressure dropping more than 20, again, with the onset of symptoms, or a diastolic dropping at all with the onset of symptoms. And we usually say a cutoff of about 10 or more. Now, if you have hypertension without a heart rate increase, this suggests some sort of an autonomic impairment. Like we see, blood pressure drop, but heart rate doesn't try to accommodate for it. So that means there's something wrong with the autonomic system. If we have an exaggerated heart rate response. So, if our heart rate goes above 100 beats per minute or above 30 beats like a 30 beat per minute or more increase, that suggests maybe hypovolemia. So basically that we've got an issue maintaining pressure because there's just not enough volume. So we have to pump a lot faster to maintain cardiac output. And this can be with patients with or without hypertension. That would be could also be due to POTS as well, that exaggerated tachycardia with respect to position change. A blood pressure drop immediately after standing that resolves at 3 minutes does not indicate someone has hypotension. Again, your pressure may drop in the immediate period. We're really looking at that 3-minute mark, like when those feedback loops should have normalized things. If it's not normal and they're having the symptoms after that 3-minute point, that's abnormal. And again, these differences may be useful in detecting whether patients like kind of what's going on, as well as points of education. Say, hey, okay, you may experience these differences immediately. Kind of like maybe do some light activity, other different things we can address it, or maybe cautiously moving from positions because these things happen. So again, just bear in mind there are differences in the manifestation. Typically, heart rate should go up by a very little amount. Blood pressure should drop by a very little amount, may even increase in some patients, but shouldn't change much. And we're really looking at the responses at 3 minutes because, again, some of these changes will be instantaneous. Our feedback loops kick in. Some people it takes a little bit longer, especially if you're older. So don't just say someone has orthostatic hypotension if you're only measuring at the immediate point. You got to measure at 3 minutes. That's the kicker here. All right. So orthostatic testing, again, when we go through it, we had the patient go through step by step. We're going to explain to them what we're going to do. They're going to be sitting still, measuring their baseline. And then, typically we go from supine to sitting first because, going all the way from supine to standing could be a little bit, the patient standing is a little bit more of an unstable situation than someone seated. So you may see different protocols in different facilities, but typically, the first step we assess is like how do you tolerate being upright at all? So we assess that in seated. and then we move on to standing. So then we ask the patient to stand, ask them for any symptoms they have, any visual changes. You're assessing it. Are they having any postural instability when we make that transition from seated to supine? And then we're going to measure blood pressure and pulse immediately just to see was there a drop. And then we're going to measure again after that 3-minute period, again, just to make sure that, that it's normalized. And we're also assessing for symptoms. If they have any adverse symptoms, obviously, if they have syncope, you're going to bring them back into bed. But again, that it's a 3-minute mark, right? It's not the immediate measure that indicates someone has orthostatic hypertension. It's that 3-minute mark, which reflects if they have it still at 3 minutes, indicates those regulatory systems aren't working at all or not effectively. And again, this is the procedure for how to follow here. Again, always asking for symptoms as we go. Now, we'll cover a little bit of the normal aerobic response to aerobic exercise. Again, we'll cover this more in cardiopulm. Quick thing to remember that your blood pressure response during aerobic exercise will be about 10 millimeters of mercury per increase in met systolic. Diastolic should stay about the same. Your heart rate response should be about 10 beats per minute per change in workload. So rule of 10, 10 systolic, 10 heart rate. Diastolic should never really change. At most 10 at the highest intensity. So diastolic stays for the most part the same. You'll have a slightly increased blood pressure response of upper extremity compared to lower extremity exercise. We'll talk more about that in our hypertension lecture. That has to do with the changes in relative vascular beds that are dilated versus constricted. Ties back to that functional sympatholysis. But generally, again, upper extremity activity is higher net blood pressure increase than lower extremity. You'll still see an increase of lower extremity. It'll just be higher compared to an upper extremity exercise at the same workload. And again, it's kind of a graph here of what we see in terms of trends. Sorry, this is a repeat slide. And in terms of resistance training, now resistance training will see a very dramatic increase in blood pressure. This is due to a lot of factors: the constriction of the vessels from compression, the sympathetic response that we get as well from exercise. We find it's oscillatory, so basically the highest peak increase occurs during the concentric phase of the lift. So in a bicep curl, for example, the highest peak increase is when you go into flexion. It levels off at the midpoint roughly, and then it increases again as you go through the eccentric phase, so the lowering part of the bicep curl, just as an example. But it will still be increasing. But the concentric phase is the highest increase during a resistance training movement, right, or a concentric lift. Eccentric phase will increase but be lower than a concentric phase. There is also a thing called post-exercise hypotension. We'll talk more about this in our hypertension lecture, that some people may demonstrate an acute lowering of blood pressure following a period of recovery. And again, we'll cover more of that in our cardiopulmonary course and how to interpret this. Basically, your heart rate should come back to about 12 beats per minute in recovery or more after a minute, and blood pressure should be back to normal at about 6 minutes, and at 90% of what it was at peak at 3 minutes for systolic. So again, blood pressure should normalize after about 6 minutes of recovery. There are some patients where it actually gets a little bit better, and we find this often in patients with hypertension, but just a thing we're going to touch on lightly because we'll cover it later on. Now, how do we measure things during exercise? So we'll learn more about this. There's a great video on this on the Cardiopulm section's YouTube channel, and we'll cover this probably more during our in that lab for Cardiopulm. But there are ways to do it as well with exercise. Basically, it's the same exact setup as you would in standing, just the patient's moving this time, and you're doing it on a bike or a treadmill. And yeah, we'll learn more of that later. Just want to introduce those concepts. Here's a case here for you guys to go through. The answer is provided in the slide, so I want you guys to go through interpreting heart rate responses to exercise and then recovery. And again, remembering heart rate recovery at 1 minute, so these are R1, 2, 3, or 4, 5, should be more than 12 beats per minute from what it was at peak. And blood pressure should normalize at 5 minutes of recovery. And at 3 minutes, it should be at 90% of what it was at peak. So this is an example. The patient this is their peak blood pressure response here. So we're going to compare these values, and the answer is here on the bottom. So probably in terms of screening, these are the most contemporary guidelines that we recommend. These were published in PTJ. They're here for you guys to reference for blood pressure. Generally, we're going to recommend taking blood pressure on every single patient. 140 over 90, proceed with usual care, contact a PCP if these findings are abnormal, monitor closely. Not much is going to change with care. Now, if someone goes above 160 over 100, probably going to hold resistance exercise, contact the PCP if it's a new finding especially, monitor closely. Patients with hypertension typically demonstrate exaggerated or may have a higher risk of demonstrating exaggerated blood pressure responses. So you just want to be monitoring that. So especially if they're above 160 over 100, that's pretty high. Now, if we get to someone with 180 over 120, we're in that hypertensive crisis. And then we're going to be assessing whether that's an urgent situation or an emergent situation. We'll learn more about that in cardiopulm with the differences between those two. Basically, an emergent hypertension is someone with a critical value, so it's either over 180 or over 120, over 180 systolic, over 120 diastolic. But with an emergency, they have signs of organ damage. So they have stroke-like symptoms. They have chest pain. They've got other issues that maybe they're having a stroke, a heart attack, or kidney failure, or flash pulmonary edema. That would be an emergency. That's a 911 call immediately. There is hypertension urgency, where they have a critical or blood pressure or in hypertensive crisis, but they don't have those hard organ signs. That's not necessarily a 911 call. That's more maybe a contact to the PCP, get them to an urgent care to get their blood pressure lowered, but they're not acutely in a situation where they are having some sort of organ damage. It could precede that though, so we need to be mindful of getting that pressure lowered quickly. Here are some values for screening for kids. These come again from those guidelines in pediatrics. And so anytime you have a pressure, it's broken down by boys and girls, so by sex, showing when it's a pressure that would indicate further examination in a pediatric patient. It's above any of these values here, again, corresponding to age. There's other ways for us to assess patients. Again, we talked about vitals. We could include different questionnaires. PAR-Q is something we want to add into our basic assessment, whether or not someone is appropriate to begin with rehabilitation services. There's a DASI score, which lets us give us an assessment of mortality. The ACSM has a physical fitness questionnaire. The most important thing, just remember that even young patients can have risk factors, and we're seeing a higher prevalence even now as our countries become more and more inactive, higher burden of cardiometabolic disease. There's also kids that have heart defects, right? So we need to be screening in pediatrics. Both men and women have issues with cardiometabolic. So everyone should be screened at least at the initial evaluation, right? There's again that old adage in medicine, never ignore an abnormal vital sign, because we're getting a reflection of how stable their body is. And with us, unlike a medical clinic where patient's going to be seated in a chair, in a PT clinic, we're going to have them move and exercise. We want to make sure that at baseline, they're stable. So there's a lot of different ways that we can add the different elements of screening, questionnaires. We can assess blood pressures during exercise. We can do a lot of different things, but the basic starts with vital signs. So we'll end here, and thank you guys for tuning in.